So good afternoon. My name is Melanie Escher, and I'm with the Arizona Telemedicine Program and the Southwest Telehealth Resource Center. Welcome to our presentation today with the Arizona Telemedicine Program webinar series. So those of you that are with the University of Arizona, the College of Medicine Tucson, faculty, residents, fellows, this session is accredited for DEI 1 hour. I will put the URL in the chat a little bit later, unless you want to grab the QR code with your phone. But again, I will put the URL in the chat in just a couple of minutes. So here at the university, we respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. So as you join today, your phone or your computer microphone were muted. We will be using the chat function for Q&A at the end. There will also be a post-webinar evaluation. CME credits only available during the live presentation, and in the evaluation you will get the 800 number and the code to text in. This will be recorded and will be available on our website later. However, CME credit is only available during the live presentation. So this was sent out to all of those that registered, the continuing medical education, the objectives, the accreditation statement, and disclosure. Again, for the attendance tracking for CMEs, the code will be found in the evaluation. If you haven't set up your profile yet in the cloud CME, you'll be able to email me or respond back to my thank you email I will send at the end of the session this afternoon. And you can ask me how to do that. All right, and be sure to check our upcoming sessions coming up from our website. And again, here's the evaluation. I will put this link in the chat at the end as well. And without any further ado, I'm going to go ahead and introduce to you Tara Sklar, who's our Faculty Director of Health Law, Arizona Law, and the Associate Director of Telehealth Law and Policy with the Arizona Telemedicine. Tara?
Great. Thank you, Melanie. And hi, everyone. Welcome to our webinar for today. I am so excited and honored to introduce Professor Megan Parker. Currently, Professor Parker is a Bigelow Teaching Fellow at the University of Chicago, but she will be starting an exciting new role as an Assistant Professor of Law at the University of Georgia in Athens starting next year. She is a prominent health law scholar, really focusing on the legal implications of telehealth, digital health technologies, and what that means in terms of democratizing healthcare, particularly in light of access to care for marginalized and vulnerable communities. Her talk today, as you can see in the slides here, is on Come As You Are, Democratizing Healthcare Through Black Church Telehealth Initiatives. And if you're interested in reading the article, I am going to just put in the chat a link to it that you can download for free, and I encourage you to do so. It's a fantastic article with a really needed perspective in the area of telehealth. Prior to becoming an academic, Professor Parker was at very reputable, prestigious law firms, including Sidley Austin and Ropes and Gray. And she also has a master's of theological studies from the Harvard Divinity School. All of these perspectives and backgrounds just make her contributions to health law very inspiring, and I am just delighted that she could be with us. So I will be moderating the chat throughout today's talk. Please, any questions, clarifications, maybe any resources that might be mentioned that you'd like to know more about, put it in the chat. We'll take note of it. Professor Parker will be presenting for about 50-ish minutes or so, and then the remaining time will be for Q&A. So with that, I'm going to turn it over to Professor Parker, and thanks so much for being with us today.
So thank you, Professor Sklar, for the lovely introduction. I'm so excited to be here sharing my work on Black churches and telehealth. So the title of my paper and my presentation is Come As You Are, Democratizing Healthcare Through Black Church Telehealth Initiatives. And for those of us who have encountered Black church traditions, you've likely heard the phrase come as you are, because this phrase is meant to welcome people of different backgrounds into the community. And so my motivation for this paper kind of started way back when I was studying religion, ethics, and politics at Harvard Divinity School, and also during my legal practice of assisting clients in the healthcare and life sciences industry. And so this paper is really the culmination of what I've learned along the way while in graduate school, law school, and also practicing within the life sciences industry and thinking about how we could expand access to healthcare in marginalized and underserved communities. My argument in the paper is that Black churches are examples of community partners that could help expand access to healthcare via telehealth, but there are some legal obstacles that could limit its promise. Before jumping into those legal hurdles and reforms, I'll start off by briefly describing the health disparities in the Black community, and then discuss the social determinants of health and how they relate to the initiatives that I propose in the paper. Compared to their white counterparts, Black people are at a higher risk for heart disease, stroke, and even cancer and infant mortality, to name a few, according to reports by the Kaiser Family Foundation. And in a study by the University of Michigan Medical School and that School of Public Health, 2,000 respondents in a study evaluating the lifetime experiences of discrimination within the American healthcare system found that 1 in 5 people experienced some form of discrimination, and that racial discrimination was actually the most common type. The social determinants of health produce health disparities. And I'm sure most of us on the call, if not all of us, are very familiar with the social determinants of health, which are the conditions in which people are born, grow, work, live, and age. And these are the conditions that shape the daily lives of individuals in a given neighborhood or in a given region. And examples of social determinants of health include poverty, lack of education. If one resides in, for example, a food desert, then they may not have access to healthy and fresh foods. But also stigma and racism are also underlying contributing factors of health inequities. And so when we're thinking about telehealth's promise to expand access to healthcare, the social determinant of health that is incredibly relevant is the lack of healthcare access in some parts of our country. So this map shows the shortages of healthcare professionals in the primary care area. Legal and public health scholars have argued that telehealth has the potential to reduce health disparities by surmounting barriers to access to care. So this map shows that in the darker green areas and in the darker blue areas, there are greater shortages in both rural as well as metropolitan areas. So you could imagine for individuals living in these areas where there are shortages that it will be difficult to make an appointment, an in-person appointment with a physician. But there are also shortages of mental health care professionals as well. And arguably, this map looks a little bit worse than the primary care map that I showed on the previous slide. For those in rural and remote communities, telehealth could mitigate the impact of access to healthcare or shortages of physicians that stem from, for example, just not having enough doctors in that particular area, or limited access to public transportation because some rural areas do not have public transportation systems such that individuals without cars may be able to travel to a doctor's appointment. But as this map shows, there are shortages beyond rural areas and in some densely populated cities. So I'm from Alabama, I'm a proud Southerner, and I'm from the Gulf Coast in Alabama. And as we see here, this is a dark blue area, which signifies that this is a metropolitan or urban area that is suffering from a physician shortage. And some researchers in 2016 wanted to investigate this very question of, well, we have studies that focus on shortages of healthcare in rural areas, but is it possible that in urban areas or in larger cities that there are shortages of physicians in certain neighborhoods within those physicians that have similar consequences for access to care? And so in 2016, a group of researchers took Philadelphia, Pennsylvania, and they examined whether one's neighborhood in Philadelphia made a difference in whether they had access to primary care. And what they found was that in the northern as well as the west neighborhoods in Philadelphia, Pennsylvania, which is where most African Americans lived, those neighborhoods had the lowest access to primary care. And so African Americans had a 28 times higher odds of falling into these lowest primary care access regions. So what does that mean? That means in Philadelphia, Pennsylvania, that overall has a sufficient number of primary care physicians. Where you live actually determines whether you have access to those primary care doctors. And it has consequences for care because the individuals that live in those lowest access neighborhoods, for example, may have to wait longer times to see the doctors that are in those areas, or may even travel outside of their trusted neighborhoods to other parts of the city to make an appointment, or maybe even leave the state if they need to make an appointment with a primary care physician. And so that brings us to telehealth's promise. In these rural and urban areas where there are shortages of physicians, an individual could instead have a remote or virtual appointment instead of an in-person appointment, and have an appointment with a primary care physician or a mental health care professional. But telehealth is not a one-size-fits-all solution to limited healthcare access. To truly democratize healthcare via telehealth, we must confront the challenges of bringing telehealth to people from diverse races, ethnicities, cultures, and even socioeconomic backgrounds. And so therefore, the potential for telehealth to increase access to care is limited by specific determinants of telehealth access. And so in my paper, I focus on two determinants that are particularly relevant to the Black community. And those determinants are or include medical mistrust and the digital divide. So according to public health scholarship, medical mistrust is not merely the opposite of trust, but instead is more negative than trust, or negative than the absence of trust, because it means that the individual that holds medical mistrust or is distrusting of a healthcare professional believes that that physician will act against their best interests or even well-being. So that means an individual who is not trusting of their physician doesn't just lack trust, but believes that that physician may, say, enroll them in a study without their consent, or not prescribe them with the pain medication that they actually need due to stereotypes or misconceptions about their race or anything else about who they are as a person. And Black Americans have generally held this distrust of the healthcare system due to a social memory of historic accounts of medical exploitation and racial discrimination, but also ongoing experiences of discrimination within our healthcare system. So starting from the historic perspective, most, if not all of us, have heard about the Tuskegee experiment and Henrietta Lacks's story. So I won't spend too much time here, but just in summary, the Tuskegee experiment involved a study where the investigators failed to provide the participants with informed consent, and the participants were actually told that they were being treated for a condition at that time called bad blood, which wasn't just one condition, it was multiple conditions, including syphilis. But actually, those individuals were enrolled in a natural history study that was designed to study the progression of syphilis over time. And those investigators withheld the treatment for syphilis at that time, even though it was widely available in 1943 when the study was taking place. And Henrietta Lacks, she had her cells harvested without her consent, and those cells are still the basis for biomedical research today. And so even though these stories, they were a while ago, but not that long ago, these stories remain within the social memory of Black communities and are a part of the hesitancy to trust and seek care within our healthcare system. But there aren't just stories of medical exploitation. Our laws also helped codify racial discrimination within the healthcare system. In 1946, the federal Hill-Burton Act, formerly known as the Hospital, Survey, and Construction Act, increased development of public hospitals and long-term care facilities while codifying racial discrimination in our healthcare system. So the Hill-Burton Act had a separate but equal provision, also called a non-discrimination provision, that was interpreted to allow for facilities that received funds to construct hospitals through this act to develop separate facilities and separate wards for Black people on the basis that they were supposed to be equal. But as we all know, the facilities were not equal in resources at all to the resources and the more well-resourced hospitals and facilities that were designated for white individuals. And Black individuals also were turned away from white hospitals, even if that meant that they would die en route to the closest hospital or facility for Black individuals. But as I mentioned, medical mistrust stems from contemporary experiences of racism and discrimination as well. As I previously mentioned, that the University of Michigan and the School of Public Health found that racial discrimination was the most common form of discrimination during a healthcare encounter. And additionally, studies have shown that Black individuals are consistently undertreated for pain based on misconceived or false beliefs about Black individuals being able to tolerate pain better than white individuals. And so due to medical mistrust, individuals may underutilize health services, not adhere to treatment recommendations, and have a lower quality of life. Researchers have found that compared to non-Hispanic white participants, non-Hispanic Black participants were 73% more likely to report mistrust in health professionals. But it's important to underscore that Black communities and other communities that deeply do not trust medical professionals are not at fault for what has been described in the public health literature as a rational coping response to racism and discrimination within the healthcare system. And so as we aim to democratize healthcare and expand healthcare through telehealth, the healthcare system must recalibrate to create a reliable record upon which trust is warranted. And at the same time, the genuine partnerships that I describe in my paper, and I will describe in the next few slides, could help strengthen that trust. Now, shifting to the second determinant of health that is relevant here, the digital divide impacts not just a lack of access to technologies needed to facilitate a telehealth visit, like a computer or having broadband access or having Wi-Fi at home or even a web camera, but also understanding how to use those tools. Studies have shown that in some elderly populations, an individual may have the requisite technology, but not understand how to access that portal to have a virtual visit with their physician. And so it's important to keep these determinants in mind as we are thinking about how telehealth can expand access to care. Some states and some researchers have been thinking through how community organizations or centers could be leveraged to address, for example, the digital divide. So I'll take the first study that's at the top of the slide. This study investigated the potential of collaboration with rural public libraries to expand access to telehealth. In some communities, libraries have a very strong history of connecting individuals with not just health information, but resources throughout the entire community. And many public libraries have Wi-Fi. And so these libraries could be leveraged for individuals who, for example, don't have the sufficient technology at home or have a trusting relationship with librarians such that they're comfortable having a telehealth encounter in a private space at the library. But we're also seeing partnerships with schools. So in Dayton, Ohio, for example, this school has partnered with healthcare providers to expand access to mental health care. And throughout the country, we're seeing schools partner with healthcare providers to expand access to both primary care, mental health care, or even to help students manage chronic health conditions and expand access to care in areas that, again, have shortages. So you may be wondering, so what does all of this have to do with Black churches? Black churches could expand the trusting relationships that these entities have with Black communities to the healthcare system and help mitigate the impact of both medical mistrust and the digital divide. Before jumping into the examples of how Black churches are already expanding access to healthcare information and connecting individuals with health services, it's important to note that the term the Black church is far from a monolith, as the term represents wide variation amongst African American Christian denominations. So there are several denominations that fit within this umbrella term of the Black church, and I won't go through all of them, but just to name some examples that you may recognize: the National Baptist Convention, the African Methodist Episcopal or AME Church, or the Church of God in Christ, also called the Kojic denomination, fit within this umbrella term of the Black church. And so the bottom line is that this term refers to a variety of Protestant churches, and that religious views may vary significantly across those denominations and even within those denominations, and even geographically. So a Kojic church in Alabama, for example, may have different beliefs from a Kojic church in California. Black churches are already important locations for promoting healthcare, and they were leveraged during the COVID-19 pandemic, for example, to expand access to COVID-19 testing, but also COVID-19 vaccinations. So this NPR article described how in Dallas, Texas, churches were the actual sites for COVID testing and also for COVID vaccinations. And what the healthcare providers recognized was that the trusting relationship, or they recognize the trusting relationship that many Black churches have with their members, but also the surrounding community. And so they sought to increase vaccination rates in the Black communities, because during that time, Black populations were some of the lowest vaccinated populations within the country. And so these collaborations helped expand information, or share information about COVID-19 to dispel myths or maybe even false information about the vaccine. A more recent example involves churches on the south side and the west sides of Chicago. So these churches have actually implemented a digital health technology in some ways, where they have a kiosk that allows individuals to access information about nutrition, disease management, or even mental health for themselves or loved ones. And the impetus for this type of technology, which is really just like a oversized iPad that's mounted on the walls in churches, was to allow individuals to search for information about certain health conditions, so that individuals could know, okay, if I have this certain disease or diabetes, these are the things that I need to be looking out for, or these are some examples of healthy foods if there are certain nutritional needs for that individual. And all of these endeavors are aligned with what some Black churches have, which are ministries or discrete social programs that are designed to address social issues such as health disparities in Black communities. I've canvassed so many church websites and seen a variety of ministries that go from addressing health disparities or promoting health information, to food pantries, to connecting individuals with legal aid clinics. I mean, there's just a wide variety of work that these churches are doing in their communities. And what I like about this screenshot from a website of a church in Alexandria, Virginia, the church is called Alfred Street Baptist Church, and it is a predominantly Black church, is that it describes how the church is committed to improving the overall health of its members, but also the community at large. And so again, we're seeing a commitment not just to the individuals who show up for church on Sundays, but also the individuals who may not even frequent the church for formal services, but may reside in the community or reside in the city and need assistance with some type of issue. Because of the historic and contemporary roles of Black churches and Black communities, this paper presents two models for Black church telehealth initiatives. So the first model is a full-blown telehealth clinic. So it's what you think it is. It's a partnership between a Black church and a local health system to establish a community-based telehealth clinic. Primary care, mental health care would be provided because, as shown in those previous slides, there are shortages of those specialty areas throughout the country. There will be non-medical technology as well as medical equipment. So in terms of medical equipment, any FDA cleared or approved devices that are appropriate for the virtual setting would be used to capture patient biometric data and transmit that information to a remote or distant physician for analysis. And then we'll come back to this last point related to the church providing community health workers to staff the front desk. This point is particularly relevant to the analysis of privacy and confidentiality issues that may exist in this model. And then finally, like the examples that I've shown in the previous slide in the NPR article, or with the kiosks that are mounted in churches on the south as well as the west sides of Chicago, we want to leverage the trust and the familiarity of the church property. And so having the virtual clinic located at a space would not only just be located at a space on the church's property, would not just be convenient, but also may be a familiar place for individuals to receive care in the telehealth setting. But if the legal hurdles that arise through Model 1 are too great to overcome, I developed Model 2, which is a designated telehealth space. So it's not a clinic, and it's simply a room, a private space that's available to the church community or the community members. And it's equipped with a computer, Wi-Fi, and a web camera or any other technology, non-medical technology that will be needed to allow an individual to have a virtual appointment with their physician. And so this type of model is designed really to address the digital divide and to allow individuals who don't have the requisite technology to go to the church or maybe even another type of community space and leverage it to have a virtual appointment. Only technical support would be provided, meaning help turning on the computer, connecting to the Wi-Fi. But through this model, because it's just simply providing a space, individuals wouldn't receive, for example, advice on their specific medical conditions or advice on anything that's personal to their health. But before I move on to the legal hurdles, I do want to note that Black church telehealth initiatives are not a perfect remedy for health disparities that stem from systemic racism and discrimination, because those are the root causes of medical mistrust. And so public health partnerships will require dual efforts that involve partnerships with trusted organizations and legal and policy-based solutions to sufficiently address systemic racism and discrimination in our healthcare system. Okay, so now jumping into the legal hurdles and reforms, or even just considerations for the two models that I present in this paper. First, I describe general hurdles to telehealth because we can't have these types of initiatives or partnerships if there are significant limitations on telehealth in general. I won't spend too much time here going into the two hurdles that I describe in the paper because those areas are not the heart of my research, but I'll just give a very brief summary before moving on to the heart of my legal analysis. So first, state laws on physician licensure are a barrier to telehealth expansion. There is wide variation in state laws related to physician licensure requirements. And because physicians generally must be licensed in the state where the patient is located, remote physicians must often complete very burdensome and repetitive application processes to obtain licensure in several states. And this could be a barrier and is a barrier to telehealth expansion in states with significant shortages of physicians that would benefit from having individuals outside of that state available to see patients. Now, during the COVID-19 public health emergency, many states created exceptions or waivers to allow out-of-state physicians to see patients within their state lines. For example, some states may require that out-of-state physicians not go through the entire licensure process, but instead register within their state. However, some of these waivers have expired since the end of the COVID-19 public health emergency. Also, at the time this paper was written, many states were relaxing the legal requirement for an in-person visit before a doctor-patient relationship could be established, allowing such relationships to be established via telehealth. And on one side, it makes sense to relax the requirement for an in-person visit because in areas with shortages of physicians, we end up in a situation where we may just be replicating similar access limitations, because if there are no places to have an in-person visit, then it gets in the way of expanding access to telehealth. But on the other hand, the in-person visit has been the hallmark of the doctor-patient relationship and has been the basis upon which trust has been developed with communities. And so when we're thinking about communities that may already have low trust in healthcare professionals, it may be challenging for physicians to get to know patients and for patients to feel comfortable sharing their personal stories if they're only having consistent virtual visits with those physicians. And so it remains to be seen, and I'm interested in reading and learning more through empirical studies about how this trust dynamic is impacted, if it is impacted, by the lack of in-person requirements in a variety of jurisdictions. Moving on to now the heart of my paper, which are the barriers that are relevant to the two models that I propose. So first, starting with medical malpractice liability, there are a specific set of challenges to telehealth expansion that exists here precisely because we're talking about Black churches, which often serve predominantly Black communities. And so as we think about the legal barriers to telehealth expansion and the importance of community partnership, credibility of and trust in that partnership is important. So when I first started working on this paper and this project, I truly didn't think there was a single example of a church that had a full-blown, completely virtual, community-based clinic on its campus. But I was excited to find this partnership between Atrium Health, which is a healthcare center in North Carolina, and a Black church, which is Mount Calvary Baptist Church. And through that partnership, they established a virtual clinic on the church's campus. And I like how this screenshot from the church's website shows how integrated the clinic is with the life of the church. So at the bottom left of this, or right of the screen, you can see the service times listed along with the details about the clinic. And this is one of the church's many social programs. And so it details how to make an appointment at the clinic, the types of illnesses that are treated as well. And you could imagine a pastor, say at maybe another church, that is doing a sermon series on the importance of health and maintaining one's health. And that pastor may hold out the physicians of the clinic as competent and culturally competent as well as medically competent during the sermon. And the clinic, for example, it would be located on the church's campus, and the church's name may even be in the clinic's name. But it is this closeness between the healthcare organization and the church that could give rise to tort liability under an apparent or sensible agency theory, even if those individuals or the churches are not controlling the medical judgment of the remote physicians, and they wouldn't be. Those physicians would either be employed or independent contractors of the healthcare provider that sets up the clinic. But a parent agency holds, and I quote, a principal accountable for the results of a third party, so that would mean the patient's beliefs about an actor's authority to act as an agent, even when the belief is reasonable, or when the belief is reasonable and is traceable to a manifestation of the principle. Courts have expanded the applicability of the apparent or sensible agency theories beyond hospitals, which, as we know, are typically liable for the acts of employed or independent contractors under the hospital's control. And they've expanded these theories to managed care organizations, or MCOs. And so like the church, with a telehealth clinic, certain MCOs, like health maintenance organizations, do not employ or otherwise control the practice of physicians that see patients within their network. But courts have relied on this doctrine to determine that the MCO, or whether the MCO created the appearance of a relationship that could have reasonably led the injured patient to believe that the physician was acting as an agent of the MCO. And so similarly, depending on the scope of the church's involvement, depending on the scope of the church's representations about the clinic and the physicians, it could be reasonable for a patient that is seen in the virtual clinic to believe that the physician is an agent in some way of the church, and then therefore the church could be liable for negligent acts under this theory. Now, there are some legal solutions that I propose in the paper. First, jurisdictions could consider allowing these types of church partners to be immune from suit for negligent treatment. In some states, HMOs are still granted immunity from civil actions, seeking to hold them vicariously liable for a physician's negligence. And so similarly, a church partner, especially the church partners contemplated in this article, could be immune from negligent suits related to medical malpractice because those church partners would not have any control over the medical decisions made by the remote physicians. Secondly, beyond church partner immunity, churches should clearly and conspicuously disclaim any relationship with remote physicians, either in both signage in the facility and in forms signed by patients. So it's clear that the physicians are not the agents of the church. But these types of terms do not prevent injured patients from filing complaints against the church and other tortfeasors in the first place. Shifting to the next topic, which is religious limitations on care and compelled disclosures, Black church telehealth initiatives raise unresolved questions about the role of religious affiliated institutions with the provision of health services. Religious institutions, such as Catholic healthcare organizations, are becoming more and more aligned with our healthcare system. These institutions are expanding access to care, some types of care, in areas where there are simply no other options for the individuals that live there. But on the other hand, some of these institutions are limiting the types of care provided, such as by banning abortions, certain gender-affirming services, or other services that may conflict with the applicable religious doctrine. Current informed consent doctrine is a legal tool that has been discussed in some of the health law literature that may be expanded to require healthcare institutions to disclose religious or moral limitations on care. Some studies, as I was researching this paper, I found some studies that evaluated whether patients knew they were going to a religious affiliated healthcare organization, and also, even if they did know, whether they understood that their care would be limited by the religious doctrine of the church or of the religious organization. And so these disclosures are believed to arm patients with information on services and alternatives such that they at least have the information about services that would not be available to them if they decide to seek care at that institution. But the merits of compelled disclosure mandates may be limited because some patients may not have viable alternatives to faith-based healthcare organizations. For example, patients who are experiencing medical emergencies may not have another choice to go somewhere else if they're in the middle of an emergency, or if an individual resides in an area where there are no other hospitals or no other clinics other than the religious affiliated healthcare providers, then again, those individuals don't really have a meaningful choice to go anywhere else because the only options are the religious affiliated healthcare organizations. Therefore, future legal scholarship must explore whether healthcare can be truly democratized if religious affiliated healthcare organizations impose religious limitations on care at all. My next barrier relates to Medicare and Medicaid reimbursement of telehealth services. So I focus on these government-sponsored programs because both of these programs have helped decrease uninsured rates for lower-income Black individuals and increase access to care. And after all, if we're positing these new types of partnerships, it wouldn't be ideal if healthcare providers who do see Medicare and Medicaid beneficiaries were not able to see them because the services are not reimbursable. Prior to the COVID-19 public health emergency, Medicare determined which locations qualified as originating sites based on where the patient was located during the telehealth service. So before I jump into the originating site and the particular requirements for a originating site, I do want to just make sure we all understand the terms. So an originating site is the site where the patient is located during the telehealth visit, whereas the remote provider is at a distant site. So there are requirements for reimbursement for both of these sites, but for the purposes of my paper, I focused on where the patient has to be, meaning what qualifies as an originating site under Medicare. Prior to the pandemic, patients were required to see a remote physician at an originating site in a clinical setting, in certain clinical settings, such as a physician office, a hospital, or a skilled nursing facility. But the originating site also was required to be in a geographic location that was a rural area with shortages of healthcare professionals. So we could see how prior to the pandemic, this is a very narrow conception of an originating site because a patient was not allowed typically to be in their home, or if a patient was in an area that did not have shortages of healthcare professionals, then the geographic location requirement under Medicare was not met. But during the COVID-19 pandemic, Medicare wanted patients or beneficiaries, especially as we were quarantining and healthcare facilities were scaling back the types of care that could be provided in person, to be able to have remote visits with doctors and to be able to continue their relationships with their physicians. And so during COVID, we saw some of these requirements for their originating sites relaxed in order to expand access to care. Congress passed the Consolidated Appropriations Act of 2023, which extends specific telehealth-related regulatory flexibilities for Medicare beneficiaries through December 31st, 2024. So within these flexibilities, there were permanent changes made under the Act, as well as temporary changes. The permanent changes were that for behavioral and mental telehealth services, there are no geographic restrictions, meaning beneficiaries no longer have to be in a rural area that has a healthcare professional shortage. In addition, eligible patients can receive services in their home. So we no longer have that clinical setting requirement where a patient had to be in a physician's office for their virtual appointment. Now you can be in your home or elsewhere. But some changes were only temporary changes, such as non-behavioral or certain non-behavioral mental telehealth services, such as primary care services. So for those types of services, the Act temporarily allows for a patient to be in any geographic location, and eligible patients can receive telehealth services in their home. But again, these changes are temporary. So actually, a few weeks ago, in May, the House and Ways Committee passed H.R. 8261, titled Preserving Telehealth Hospital and Ambulance Access Act, which provides a 2-year extension to current temporary Medicare telehealth waivers, like the ones listed on this slide and others that are not listed on this slide. Therefore, these waivers and others will remain in place for 2 more years, so until December 2026. This extension will have a huge impact on future access to telehealth, but this is still a temporary extension. Black churches are organizations or nonprofits like some other, not exactly the same, but similar to some other community organizations that provide social services to small communities. And so even though these general telehealth laws and regulations were written with good intentions on providing guardrails for telehealth to prevent misuse or maybe even fraud. Because these changes are not permanent, they may limit potential investments in collaborations between healthcare organizations and nonprofits like Black churches. Healthcare providers may be a bit more wary of establishing these kinds of partnerships and investing the funds on the front end to set up these clinics, or even to set up, if a church wanted to set up a designated space, if over time reimbursements are only tied to certain requirements and those requirements expire on a particular date. And once the temporary changes expire, unless there's another extension or unless these changes are made permanent, pre-pandemic narrow definitions of originating sites will prevent providers from receiving payment for virtual visits for example, primary care at originating sites like churches in areas that are not rural areas that suffer from health professional shortage areas. And for example, under Model 2, a church is not a clinical setting. And so therefore, if a beneficiary wanted to have a telehealth visit in the designated church space, then they may not be able to receive those services if the temporary changes for non-behavioral mental telehealth services are not extended or made permanent. And then finally, once we revert to pre-pandemic requirements of a clinical setting, meaning you can't be in your home or elsewhere for a non-behavioral mental telehealth visit, if there is a shortage of qualifying clinical sites in the area, we may replicate similar limitations on access to care. From a Medicaid perspective, so as a reminder, Medicaid is a federal state assistance program in which the states administer Medicaid programs in accordance with federal standards. And so what qualifies for reimbursement depends on the specific state. Similar to the federal Medicare programs, state Medicare programs often limit the types of settings that qualify as originating sites. So several states have very broad definitions for originating sites. North Carolina has a policy that is pretty ideal because it allows for a patient to be anywhere, whether they're at a healthcare facility, a school, a community site, and the policy explicitly states there are no restrictions on originating sites. In contrast, some states stipulate a list of qualifying originating sites. For example, prior to the pandemic, New York had such a list that included physicians or dental offices, hospitals, as well as some non-traditional settings like schools or patients' homes. But like the federal Medicare program, some states like New York temporarily relaxed those limitations during the public health emergency, or at least through December 2024. And so last but not least, I'd like to briefly discuss privacy and confidentiality risk and focus on Model 1 because Model 1 is a clinic, and so it will be subject to HIPAA. Before I jump in, I do want to briefly note that, as I mentioned during one of my first slides, it's important to be aware of the particularities of certain communities, of certain underserved and marginalized communities. And so for the Black community, some studies have shown that Black people have a heightened awareness of privacy and confidentiality risk. For example, this study at the top left of the slide evaluated pre-experience perceptions about telehealth among African American and Latinx communities, and found that Black Americans expressed more concern about privacy and confidentiality regarding, quote, the use of the internet for the transmission of personal information. And similarly, the second study at the very bottom right of the slide investigated the acceptability of telehealth to manage certain mental health conditions in African American women. And most of the concerns centered around privacy and confidentiality and maintaining video call connection. So shifting back to Model 1, the telehealth clinic itself would fall under the purview of HIPAA because HIPAA applies to covered entities such as a healthcare provider that electronically transmits certain types of health information in connection with certain types of transactions. And so it's obvious, like the telehealth clinic and the provider would be a covered entity that would fit within that definition. But the church itself would not be a covered entity merely because it partners with the healthcare provider, such as a healthcare system or a physician's office, to establish the clinic. Yet, depending on the church's involvement with in the type of services that may be contracted or outsourced to the church may fall squarely within HIPAA's definition of a business associate, which is an entity that is providing certain services that use protected health information to, or use or provide certain information to the covered entity. And so, as I mentioned in one of my slides, the church may provide community health workers to staff the front desk. And so if the church is employing and providing those services on behalf of the covered entity, then those individuals will likely come across and use protected health information and be deemed a business associate under HIPAA. And so therefore, both entities, the covered entity as well as the business associate, will be required to comply with certain parts of HIPAA's privacy as well as HIPAA's security rule. Now, despite the potential benefits of having the church involved with selecting who would serve as the face of the practice and having community members employed by the church to provide certain front desk responsibilities, there are some potential implications from a HIPAA liability perspective. So first, the business associate could be directly liable for violating certain parts of HIPAA's rules. And then secondly, the covered healthcare provider may be discouraged from outsourcing these responsibilities to the church because the church may be vicariously liable for any of the church business associates' potential HIPAA violations if that church is acting as an agent under the federal common law of agency. I won't go too far into the details, but if you're interested, I dive into the Federal Register notice, which gives more context for this provision related to the potential vicarious liability of the covered entity. And I discussed this in the paper, but at a very high level, the church likely, and any other community organization likely, would not be aware of the tedious and very technical requirements of HIPAA such that they would be able to maintain compliance on their own. And therefore, the healthcare provider would likely have to provide guidance and instructions or even training to the individuals that are staffing the front desk and employed by the church. And therefore, given this closeness between the covered healthcare provider, it is likely that the church will be deemed an agent, and therefore any violations of HIPAA could subject the healthcare provider to liability. So what are some approaches to minimize the risk of church and healthcare provider liability? And not just to minimize the risk of liability, but also to minimize reluctance to partner with other trusted institutions that are not as well versed. Well, first, maybe instead of the church providing those services and contracting with the provider instead could select those individuals. But this may impact the strength and the effectiveness of the partnership because the church has a closer proximity to the community and who is most trusted within the community. And so a solution that is really potentially the best of both worlds is to allow the church to recommend individuals for consideration to the healthcare provider. And then the provider would ultimately make the decision on who they hire and who is most qualified from their perspective. And lastly, if the legal hurdles that I have discussed related to Model 1 are too great to overcome, Model 2 is still available. It is a designated telehealth space, therefore it would not be subject to HIPAA. The church would not be a covered entity or a business associate. We don't even have a healthcare provider. And so therefore, they wouldn't be bound to HIPAA's requirements to maintain certain security measures. There may be specific state-specific laws that govern these types of spaces, but those laws are outside of the scope of this presentation and will be addressed in future projects. So in closing, the bottom line is that even if protected health information is not shared between the church and the telehealth clinic or individuals who use the designated telehealth space and church staff, participants may have the false impression that church members have access to their personal information. And therefore, it is important that through these partnerships that Black churches or any other community organization limit unconsented access to patient health information, even for well-intentioned reasons like prayer or connection with other types of resources. And with that, I will open the floor for questions.
Well, that was terrific, Megan. If we were in an in-person audience, I'm sure you'd be hearing a very loud round of applause right now. We have a few minutes. I haven't yet received any questions, but please do feel free to type them in the chat. I thought this was such a comprehensive approach to this issue of, in general, like how to improve pathways for access to care, particularly among Black communities using trusted, familiar spaces like the church. And I was curious about your thoughts and applying your research to other marginalized communities and vulnerable groups, maybe even like undocumented and other churches. And I'd love to hear your thoughts on that.
Yeah, absolutely. So one of my main goals for this paper was really to help further or even start a conversation about how Black churches are just some examples of how trusted institutions or community organizations could and should be leveraged to expand access to care. But I definitely believe that in undocumented communities, I talked to a doctor actually during one of my many talks related to this paper, who was saying that in some Muslim communities, there is deeply held medical mistrust and how there are trusted organizations that could be leveraged to help expand access to care and just information that could be shared to help increase maybe some just unknown information about what could lead to some distrust between that community and some healthcare professionals. And so I'm sure that as I dive into this, I will find that across many backgrounds, different backgrounds and populations, there are many other trusted organizations that we're simply underutilizing.
Yeah, actually related to that, this modeling you have of the Model 1, the Model 2 is just so helpful. And then to go through, Model 2, I think most people on the call may be more familiar with, particularly the role of libraries and community centers. That is something, I know you brought up the Mount Calvary example. In your experience, have Black churches or other faith-based groups or other third-party entities, is that as prevalent as it sort of seems? Is it the trajectory increasing? What are your thoughts on that?
Yeah, so churches have been promoting the importance of health and providing health information. And so a lot of churches are doing that through their health ministries. The virtual clinics are a bit rarer and harder to find, but there is a good number of churches that have in-person clinics on their campuses or are even planning to start in-person clinics. So I think we're seeing this trend towards not just providing the health information, but thinking about, well, why don't we just provide the services? And so how can we do that for the communities in which we sit?
That's great. That's actually a great segue to another topic that we've been emailing about, which is, could these virtual opportunities create any kind of disincentive from in-person care? And that might actually have a bigger implication from a congregation perspective too, if you're trying to marry these two ideas together, healthcare and worship, what would be the impact there? Yeah, love to hear more on like potentially disincentivizing in-person care.
Yeah, so I worry about this. A lot of things keep me up at night about this, and that's one of them. But it's a tough question because right now there are so many people that just don't have access to any care. because there are shortages of professionals in the urban neighborhoods where they live and in the rural areas where they live. And so the way that I think about this is that it's the second best solution to addressing the issue of shortages of care. And as we're focusing on telehealth's potential, it's still important to think about what we may lose, if anything, from adding more and more virtual touch points within our healthcare system. And in some settings, telehealth is not equivalent to in-person care, And so these are some of the questions that it seems like the medical community is contemplating. And I know the American Telehealth Association has encouraged the community to develop some policies and guidances on just when is it truly appropriate and when is it not. Yeah.
Oh, well, we could keep talking for a long time. We very much hope to have you back again. I'm sorry. Thank you, Professor Parker. I'm going to turn over to Melanie to wrap this up. Thank you so much.
Thank you.
Again, thank you, Professor Parker and Professor Sklar. So again, this is with the Arizona Telemedicine Program in the Southwest Telehealth Resource Center. You will have an evaluation link. I also put that in the chat. And any of those that are with the University of Arizona College of Medicine, Tucson, this was accredited for DEI credit. Again, thank you for joining us today. This is recorded and it will be on our archive section of our webinars, and I will be sending that link out to everybody after we finish. Thank you, everybody, for joining us, and please check again for upcoming events. Thank you.
Thank you.
You.